So now it is my pleasure to present our next speaker, Dr. Carrie Bratton. She's an assistant professor of OBGYN and reproductive biology at Harvard Medical School. And she's in the Department of OBGYN at the Brigham and Women's Hospital, where she is the medical director of the Fish Center for Women's Health. And Dr. Bratton will be talking to us about an incredibly common issue that we all need to know about, which is an update on contraception. Thank you.
Thank you, everyone, and thank you for having me today. And thank you. I have no financial disclosures today. So why should we care about contraception? Why should everyone care about contraception? Well, the truth is that most Americans want 2 children, and that means that women spend about 3 to 5 years either being pregnant, postpartum, or trying to get pregnant, but about 30 years trying to avoid pregnancy. So the vast majority of a woman's life is spent trying to avoid pregnancy as opposed to becoming pregnant. About half or almost half of all pregnancies in the United States are unintended, almost 3 million. And almost 5% of reproductive age women will have an unintended pregnancy every year. The US also has one of the highest unintended pregnancy rates in the developed world because US women are less likely to use highly effective reversible contraceptive methods than women in other developed countries. So our objectives today are to understand differences in real-life effectiveness of various contraceptive methods, to understand the benefits and risks of long-acting reversible contraceptive methods, which I'll call LARC from here on out, to describe available LARC methods, how to use the CDC contraceptive guidelines, which are the medical eligibility criteria, or MEC, and the practice management, selective practice management guidelines, or SPR. And then finally, we're going to have a little discussion about the impact of COVID on contraception access and some tips for provision. Starting with effectiveness, this is a chart that you guys often seen from our contraceptive Bible called Contraceptive Technology. And what you'll see is the most common methods of contraception ranked by tier, with tier 3 at the top being the least effective and tier 1 at the bottom being the most effective. And what you'll see is that there are 2 columns. The perfect use column describes efficacy, or rather in this chart, it's actually failure rate, percent experiencing pregnancy in the first year, if the method is used 100% perfectly, so in study settings, for example. The other column is typical use, which is how people use the methods in real life. And what you'll see is that for especially tier 2 and tier 3 methods, there's a pretty significant difference between typical use and perfect use, indicating that there's something about the way that the method is used or what the user has to do that can lead to failure. Down at the bottom, we see our tier 1 methods, which include our IUDs and our implant and sterilization, where there is essentially no difference between the perfect use and the typical use. And this is why 46% of unintended pregnancies occur in contraceptive users. So it's not that women are not trying to contracept, but most contraceptive failures come from inconsistent or incorrect use. Only about 5% of unintended pregnancies are related to true method failure. And here's just a graphic of that to show women at risk of pregnancy and then unintended pregnancy. And that you can see that 68% of women use contraception consistently. But then of the pregnancies, 41% result from inconsistent use and 54% result from non-use. So in addition to using a method that is effective, women also have to continue their method for it to be effective. And here is another chart that also tiers the methods in a similar way, with the tier 1 methods being at the bottom and the tier 3 methods being at the top. And what you'll see is that there's an interesting parallel in terms of continuation at 1 year between the tiers and their effectiveness. So tier 3 methods are not only the least effective, but they are also the most likely to be discontinued. Tier 1 methods are not only more effective when used, but they're also more likely to be continued. Obviously, sterilization is permanent and can't be discontinued, but even the LARC devices have continuation rates of about 80%, which is better than any of the other methods. This is the case for long-acting reversible contraception. LARC methods are effective and forgettable. They are user-independent. Traditionally, sterilization was the method that women chose when they wanted something forgettable. However, as you can all imagine, sterilization is not reversible. And so that could lead to women choosing it for the convenience, but then ultimately regretting it or not having been completely sure that they didn't want more children. And especially in young women, we see potentially high rates of regret. Women choose sterilization under the age of 30. So what are some characteristics of IUDs and implants? They're highly effective, they're safe, they provide long-term protection, they have a single motivational act for insertion, meaning that people don't have to think about them every day or with every act of intercourse. They're immediately effective, and there's also rapid return to fertility upon removal. As I mentioned, they have high continuation rates because of high satisfaction rates. And they're also appropriate and safe for women with a variety of medical problems. And because of these sort of good characteristics, the use of LARC has increased in this country over the last couple of decades. And as you can see, in 2002, only about 2% of women were using a LARC device, whereas now our most recent data is from 2014, where we have 14% of women using either an IUD or an implant. Oops, sorry. And this is also just a chart from a study that I really like. This is from the Contraceptive Choice Project, a large cohort study of contraceptive efficacy and behaviors where women were offered any contraceptive method of their choice at no cost. And what you see is sort of a survival curve according to method and broken down by age. LARC is at the top, and then PPR stands for pills, patch, or ring, so short-acting combined hormonal methods. And what you can see is that not only does LARC have much greater effectiveness or much lower rates of unintended pregnancy, but the rates are also the same regardless of whether you're under 21 or over 21. For short-acting methods like pill, patch, and ring, what you see is that not only are they less effective, but there's a huge age discrepancy. So if you are a young woman under the age of 21, not only are you less likely to have effective contraception than with a LARC device, but you're less likely to use it effectively as compared to someone who's older. So LARC devices are sort of very highly, very well suited for young women who sort of have more risk of inconsistent use of other methods. Let's move on and talk about intrauterine contraception. There's two basic categories: non-hormonal, which includes one device, the copper IUD, and then progestin IUDs, of which there are 4 brands, 3 types. The levonorgestrel IUD with 52 milligrams has 2 brands, and then there's a 19.5 milligram IUD and a 13.5 milligram IUD. So starting with the copper IUD, Paragard is its trade name. Its mechanism of action is that it produces a foreign body effect in the uterus. It does that by creating a sterile inflammatory response, which is toxic to sperm and ova and impairs implantation. And then as you can see from the picture, there's also sort of a copper coil and then copper bands around the plastic. And those copper ions are slowly released over the lifespan of the device, and those add to contraceptive efficacy by further increasing the inflammatory response. A copper IUD has a failure rate of 0.5 to 0.8 in the first year. And over time, over 12 years, it gets up to a max of 2.2% pregnancy over 12 years cumulatively. In this country, it's FDA approved for 10 years, but clearly we have efficacy data showing good efficacy up to 12. Levonorgestrel IUDs with 52 milligrams contain 2 brands, Mirena and Liletta. Mirena, many people have heard of. Liletta is a device made by a nonprofit pharmaceutical company that came out in 2013. The goal was to bring a lower cost version to the market. These devices are exactly the same in terms of their size, shape, dose, efficacy, and bleeding pattern. They contain 52 milligrams of levonorgestrel. They release about 20 micrograms daily in the first year, which goes down to about 14 micrograms towards the end of the lifespan. These also, like any foreign body, will produce a foreign body effect, but the contraceptive efficacy of these devices is also enhanced by the progesterone causing endometrial thinning and decidralization, and thickening of the cervical mucus. These devices have a failure rate of 0.1 to 0.2 in the first year, with a cumulative pregnancy rate of 0.5 to 1% at 7 years. The Mirena is currently FDA approved for 5 years, the Liletta for 6. There's evidence-based use for 7 years of both, and studies are continue to be ongoing for FDA approval for extended use for both of these devices. The Skyla is the smallest and lowest dose IUD, and I'm going to talk about it briefly because it's likely to be sort of phased out over the next few years. It has a lower dose of levonorgestrel. It's approved for 3 years of use. The frame and the inserter are both smaller than the 52 milligram IUD. And because of the lower dose of hormone, there's also much less amenorrhea or reduction in bleeding. The smaller frame was developed to have less pain with insertion and lower expulsion rates. The data is a little bit mixed. And this device has a first-year failure rate of 0.3 and a 3-year cumulative failure rate of 0.9%. The reason why I think it's going to be phased out is that Kyleena is on the same small frame, but has slightly more hormone and is therefore effective for contraception for 5 years. And so in practice, the Brigham has stopped carrying Skyla because the benefits of the smaller frame are the same as with the Skyla, but it has greater benefits in terms of 5 years of use. The first-year failure rate is 0.16 per 100, and the cumulative 5-year failure rate is 1.45. All right, so what do we have to think about in terms of side effects with the levonorgestrel IUDs? Well, all of them are going to disrupt bleeding patterns in some way. All of these devices produce extra bleeding and spotting for the first 3 to 6 months as that decidralization process is happening. Mirena and Liletta cause a significant reduction in bleeding over time. Up to 80 to 90% of total blood is decreased. And the Mirena is FDA approved also for the treatment of menorrhagia. After about 8 months, only 50% of women have no real menstrual bleeding, just spotting. And really only about 20% of women will have any type of regular cyclic bleeding. That being said, just one important thing to know about these devices is that while bleeding patterns may be altered, ovulation and normal hormonal cycling continues with all of these methods. So whether women are getting, quote unquote, getting their period or not does not affect their ovulatory function, and that can be confusing for patients. Skyla and Kyleena, as I said, because they have lower doses of hormone, have less amenorrhea, more commonly have either light cyclic bleeding or light irregular bleeding. Hormonal side effects are rare because the hormone is primarily secreted in the uterus. Serum levels are less than 20% that of an oral hormonal medication. But when women do have hormonal side effects, they tend to be PMS, progestin-related side effects like mood, skin changes, and hair changes. There's actually well documented to not be any weight gain associated with these devices. What about the contraceptive implant? It's called Nexplanon. It is FDA approved for 3 years, but there's evidence-based use for 4 to 5. It's inserted subdermally over the triceps muscle and can only be inserted by clinicians who've completed an FDA-mandated training. This is probably the most effective method of contraception, including sterilization. It has a sort of reported pregnancy rate of 0.38 per 100 women years. However, almost all of those pregnancies occurred with rapid return to fertility in clinical trials, as opposed to pregnancy with a device in situ, which has really only been documented in women who are on enzyme-inducing medications. There are also very few absolute contraindications, including current active breast cancer, acute liver disease. Otherwise, is acceptable for almost any other medical condition. Side effects with the implant are bleeding. The pattern of bleeding is very irregular because it's a moderate dose progestin that disrupts ovulation, but doesn't completely suppress bleeding. About 20% of women experience amenorrhea. About half of women have some sort of normal amount of bleeding, but in an irregular pattern. And about 25% of women experience what we call an unfavorable bleeding pattern, either heavier or more prolonged than what they had prior to insertion. Most discontinuations are for abnormal bleeding or heavy bleeding. hormonal side effects do occur, but are less likely to lead to discontinuation, and in general are less sort of prevalent than may be expected from a progestin-only method, probably because etonogestrel is a third-generation progestin with a better side effect profile in general. So I mentioned this before, but I'm just going to say sort of explicitly around the extended use of LARC. There is strong data for extended use beyond FDA approval durations for the etonogestrel implant, the copper IUD, and the 52 milligram levonorgestrel IUDs. For the etonogestrel implant, like I said, no pregnancies have been reported in women who use their implant for up to 5 years. Over 500 women were studied. For the levonorgestrel 52 milligram IUD, as I mentioned, there are studies showing a 0.5% pregnancy rate at 7 years. And for the copper IUD, there are studies showing a 2.2% cumulative pregnancy rate at 12 years. So our Brigham and Women's and Planned Parenthood Federation of America family planning divisions recommend that you can use the implant for 4 to 5 years, the levonorgestrel IUD for 6 to 7, and the copper IUD for 12. So what do you guys need to know as non-GYN providers? Well, first of all, that women do not need to rush to replace these devices. There were many panicked phone calls, especially during COVID, about, oh my goodness, my IUD expired 2 weeks ago. It didn't expire, it still works. There's a significant amount of leeway in terms of time to think about replacement. Decisions should also be made on an individualized basis with patients. That considers their age, their baseline fertility, time to menopause. I have women who get to year 7, but they're 50 and they think that they're almost menopausal, and we can keep them for up to 8 to 10 years potentially to get through that transition at a time when baseline fertility is incredibly low, and any very, very small potential change in efficacy is likely to be not at all of significance in someone with such low baseline fertility. It is also important to consider in young patients whether they're going to replace with another highly effective method. So if someone says, I'm concerned about having my IUD for more than 5 years, I'm going to use the condoms instead, they're obviously replacing with a method that is much less effective. All right, so getting a little bit to COVID and what we've experienced during COVID. You, as I am, may be sort of starting to return to more normal clinical provision. However, even at the peak of COVID in our state here, contraception has been considered an essential service. And that is because an unplanned pregnancy is a significant morbidity in a short term. Many guiding organizations, including the American College of Obstetrics and Gynecology, stated that patients should be able to access all types of contraception throughout the pandemic, including implants and IUDs. There may be a need for more bridging if access is limited, but this should be available, and we at the Brigham at least maintained availability throughout. The other thing that I noted anecdotally during COVID was to be aware of changes in sexual behavior and to not make assumptions about how much sex people are having, whether they are quarantined or working or have a partner or not. Some people have a partner, but were physically separated from that partner. Some people you would have expected to be separated from their partner, but were not. And thus it's important to be explicit about how much, if any, sexual activity people are having if they might be more isolated. Another lesson that we've learned from COVID is that telehealth is actually ideal for contraceptive counseling. Obviously, procedures and devices can't be provided via telehealth, but a large bulk of what I do is counseling, and that can all be done very easily and nicely via a televisit. Patients obviously need referral for an implant or an IUD, as well as a clinic visit for depot administration. But almost any patient who wants a pill, patch, ring can have those safely prescribed without a clinic visit. Pelvic exams, pap smears, STD screenings are not needed. Any contraindication to estrogen can be gotten through history. And then really the only physical exam requirement for estrogen-containing contraception is a blood pressure measurement. And anytime within the last year that's documented in your chart is considered reasonable for providing these methods. The other thing that we have paid a lot of attention to is advanced provision of emergency contraception, especially when sexual behavior may be less predictable and when access may also be more limited. So just a word about emergency contraception. There are 3 available methods. The leave-in egestrol, known as Plan B, is probably what many people are the most aware of. It is FDA approved for 72 hours after unprotected intercourse. It does have potentially some effect for up to 5 days. The thing that's important to know is that it has decreased efficacy in women with a BMI over 25 and essentially has no efficacy in women with a BMI over 30. So for any obese patients, it's really not helpful for them to use Plan B. And while many women may obtain it without a prescription because it is over the counter, it's important when, if this comes up in discussion, for women to be aware of the fact that they really don't get any effect using Plan B if they have a BMI over 30. So the benefits, as I mentioned, is available over the counter. And a hormonal method like pills can be started immediately after use of Plan B if that's what the patient desires. The second method of emergency contraception is ulipristal or ELA. This medicine is a progesterone antagonist as opposed to a progestin. It works by delaying ovulation and can do so even after the LH surge, which is different from the leave-in egestrol. That's why it's more effective for up to 5 days than Plan B. It also has some decreased efficacy with high BMI, but does maintain some efficacy between 25 and up to 35, with decreased efficacy only documented over a BMI of 30. The downside is it is by prescription only, and it's less available. It's not stocked by most pharmacies, and the pharmacy may need a day or 2 to stock. So prescribing it on day 4 after unprotected intercourse can be tricky. I've had patients for whom I've had to call 10 pharmacies to find it. But that's why advanced provision can be so very helpful, is that for the women for whom ulipristal is a better emergency contraceptive, for them to have it in their medicine cabinet when they need it is ideal. The other downside is that you have to wait 5 days to start a hormonal method. Because it's a progestin antagonist, if you then start a method that contains progestin, it can decrease the effect of the ulipristal. So women have to wait 5 days to start a new hormonal method. And then finally, the copper IUD is the most effective method of emergency contraception. It is essentially over 99% effective at preventing pregnancy in the setting of unprotected intercourse. However, obviously it requires a clinic visit, and it's really only ideal for women who otherwise wanted a long-acting method. All right, so contraceptive eligibility, who can have what methods? And as I mentioned, this is where CDC guidelines are really helpful and really user-friendly to any medical provider. You can just Google CDC MEC and it's the first thing that comes up. There's also a very handy iPhone app. And basically what this document does is it categorizes contraceptive methods by medical condition and gives recommendations that are category 1, meaning no restriction on use, category 2, generally the benefit usually outweighs risks, category 3, generally not recommended unless other options are not available, and category 4, which is absolute contraindication. And here's just an example of how the chart looks, or how the gradings look for 2 common medical conditions in young women, hypertension and headaches. And what you can see is that for hypertension, estrogen-containing methods, the COC or patch ring, which is combined oral contraceptive, are category 3 and 4, meaning generally or not at all recommended in women with hypertension, whether it's adequately controlled or not. But any IUD is category 1 or 2. For headaches, you can see that any non-migraine or migraine without aura can use any method, but women with migraine with aura, regardless of age or other risk factors, should not use estrogen-containing contraception. Then the SPR is the selected practice recommendations, another guideline for just sort of like, how do I start it, when do I start it, who, and what do I need to do before? Again, a very nice Googleable document. And here's just an example of sort of how to initiate oral contraception. It's a little textier, but basically it says that the only, physical exam that finding that you need for oral contraception is blood pressure medicine, and then goes into some commentary about why, and refers back to the MACs. There's also sort of guidance on how to be reasonably certain a woman's not pregnant if they're using an IUD or a method that can interfere with pregnancy. And then guidelines about transitioning from one method to another. So if you're going from one thing to another, when do you need backup? How much backup do you need, etc. So some take-home points, challenges with correct use, adherence, and continuation of short-acting contraceptive methods is the leading contributor to undesired pregnancy in the United States. We have really good guidelines from the CDC to help clinicians determine who, when, and how contraceptive methods can be used. Increased use of LARC methods holds significant promise in reducing unintended pregnancy rates. And finally, during COVID, access to LARC really should be preserved. Primary care providers should be comfortable counseling and prescribing contraception via telehealth as needed. So thank you. We're going to go on to our audience participation slides. The first question is, which of the following LARC methods does not have evidence to support extended use? The levonorgestrel IUD 52 milligrams, the Mirena and Liletta, the levonorgestrel IUD 13 or the Skyla, the Paragard copper IUD, or the etonogestrel implant Nexplanon. So just to reiterate, which one does not have evidence for extended use? Everybody's changing their mind. All right, it looks like the responses have sort of starting to trickle out. We have 79% saying the Skyla, or 80% saying Skyla. And let's see. That is correct. So the Skyla, the levonorgestrel IUD 13.5 is the only one that doesn't have evidence for pregnancy prevention greater than 3 years. So for this device, exchange should be encouraged at the 3-year mark. That being said, for everything, you know, nobody's concerned about a day or a week or a month. We're talking about, you know, multiple months being the time frame into which people should exchange their devices. All right, next question. Which patient is not eligible for a telehealth new prescription of combined oral contraceptives? All of these patients have normal blood pressure documented in the chart within the last 6 months. Is it A, a 19-year-old gravida 0 woman with recently treated chlamydia and type 1 diabetes? Is it B, a 41-year-old gravida 2, para 2 with a recent new partner whose BMI is 35? Is it C, a 21-year-old gravida 0 with migraine with aura who has no cardiovascular risk factors? Or is it D, a 45-year-old gravida 3, para 3 monogamous woman with fibroids and menorrhagia? All right, so we're getting up to about 160 votes, which is pretty much where we were last time. But the majority of people saying C, a 21-year-old gravida 0 with migraine with aura. That is correct. Migraine with aura is a contraindication to combine oral contraceptives regardless of age and other risk factors. While the absolute risk of stroke is low in young women without other risk factors, the relative risk is still roughly 7 to 9 that of women without migraine, taking the sort of absolute risk from about 2.5 per 100,000 to 36 per 100,000. If estrogen-containing contraception is ever prescribed to women with migraine with aura, it should be done by a contraceptive expert in concert with a neurologist or headache specialist. And there are those rare women, but they are rare and should be treated by specialists. I believe that's what I have. There are some references. I know I only have 30 seconds left, but if there's time for questions and that's okay with the moderator, I'm happy to take them.
So I think what we're going to do, first of all, I want to say that was an excellent talk and thank you so much. And also for reminding us how we can do a lot of telehealth counseling using this information. But I think what we're going to do in the interest of time is hold the questions for the Q&A. Are you able to join us, or?
I'm not able to join for the Q&A, unfortunately.
No worries. I'm actually going to send you a little message with the questions, and if you could, give information, that would be great. But again, thank you so much for your time.
Thank you so very much, and thank you to everyone for being here.